Welcome back. I'm nurse educator Chelsea, and today we're going to be talking about pulmonary embolism. A pulmonary embolism is when a blood clot or blood clots form in the lungs. It can present with different symptoms, including tachypnea, dyspnea, tachycardia, chest pain, diaphoresis, hemoptysis, or PEA arrest. When a pulmonary embolism is present, this can also be associated with VQ mismatch, which means that the alveoli in the lungs are ventilated, but there's a lack of perfusion. Now, for diagnosis, the gold standard is a pulmonary angiogram, but not all hospitals are able to perform this test. So the next best thing would be a CT angiogram of the chest. This would be using IV contrast. Now, if a patient has a contraindication to IV contrast, such as an allergy, acute kidney injury, or chronic kidney disease, what we would go to next is a VQ scan. Now, VQ scans are not very accurate. They're only able to diagnose about 20 or 30% of pulmonary embolism. If you see an elevated D-dimer level in your patient's blood work and there's not been a CTA of the chest or any other testing done to rule out blood clots, you should really contact your provider and see if they want to investigate that further. So as you saw in the title of this video, pulmonary embolism also has a sneaky sister. The sneaky sister is a DVT. This is because in more than 70% of cases of patients that are diagnosed with a pulmonary embolism, a DVT, typically in the lower extremities, is also found. So if an ultrasound of the lower extremities for your patient has already not been completed, you should discuss with the provider if this is something that they want to follow up on. So treatment for pulmonary embolism and DVT can go a few different ways. In the hospital, patients can be started on a heparin drip, or they can be started on subcutaneous Lovenox injections. While in the hospital, patients are usually transitioned to an oral anticoagulant unless it's contraindicated. These oral anticoagulants usually include, but are not limited to, warfarin or Coumadin, Pradaxa, Xarelto, or Eliquis. Now, if your patient's going home with warfarin or Coumadin as their oral anticoagulant and their INR level is not yet therapeutic, which is typically between 2 and 3, they may need to go home with subcutaneous Lovenox injections. If a patient does need to go home with subcutaneous Lovenox injections, they're typically twice a day, and you will need to educate your patient and/or family members, caregivers, how to do these injections. In circumstances where oral anticoagulants are contraindicated, if there are DVTs present, an IVC filter may be considered. Patients that are in the hospital with pulmonary embolism are often anxious, so it's important to reassure them, comfort them, and also educate them on their medications, diagnosis, and plan of care. So I hope you found this video helpful today and maybe learned something or just had some knowledge refreshed. So if you found this video helpful, please rate, review, and subscribe to get the latest updates from